Good afternoon to everybody, and welcome to this session on access to PDMPs, with their unique nature, unique specific characteristics that we would like to address during this session. My name is Philip van Wilder. I'm honored to be the moderator of this session. Honored because I'm surrounded by a panel of experts who will all bring their own view, their different perspective on this access to these specific products. I will have here on my right side first Mrs. Doermann from the German Ministry of Health, with a lot of experience on policy side relating to blood, plasma derivatives, who will bring us also insights to the recent evolutions in the German regulations on that aspect. After that, we'll have Tomasz Kluszczynski from ACESO, if I'm right, from Poland, with an international track, I may say so, on HTA and health economy, relating to a lot of innovative medicines, but also on plasma-derived medicinal products in particular. So an international perspective on cost containment, exemptions to cost containments, which will obviously, I guess, be of interest to this audience. Then Frank Willersin, who will bring us the perspective of a patient as medical doctor also, on alpha-1 trypsin deficiency. So another perspective with a lot of insights, again, real insights, practical insights in that disease. He's actual president also of the Alpha-1 Plus Patient Association, if I'm not wrong, which was launched about 10 years ago. And finally, Jervelund from Copenhagen Economics. Economic point of view on the specific nature and characteristics of these plasma-derived medicinal products. So I guess that with this panel, we will have a diverse view on the issue. We'll start the session by two presentations, by Christian and by Frank. I would propose to keep all your upcoming questions to the session just after those presentations, which will be a Q&A session, which can be very interactive and go from one speaker to the other and from the other to the other panelists also, if that's convenient. So I wish you an instructive session, and I give the word to Christian for the first presentation.
Thank you very much, Phil. Perfect. Thank you so much for having me. I'm really glad to be here and try to set the scene for this session around access to PDMPs and the unique nature of PDMPs, and more broadly around the economics of plasma and also implications of some of the policy changes and regulatory changes we're seeing that are coming up that have various consequences and implications for PDMPs. First, a little bit about myself and the company. Copenhagen Economics is an economics consultancy. It was founded in 2000. Actually, I think that maybe the story of our founder is a good telling for what we try to accomplish and what we try to accomplish in the pharmaceutical space, in the medicine space. He went to Mozambique as a trained carpenter and tried to help local companies build small-scale businesses. And all of a sudden, while working hard at that, at the ground, a new policy suggestion, policy changes came about in Mozambique that totally destroyed any kind of incentives or any motivation to build your own small-scale business and try to make that into your livelihood. And that's where he kind of realized that, understanding implications of regulations and policy, it has so massive forces of change and implications that to understand that and to devise advice on that may have even more impact than working as a carpenter. So he went back and in a quite late age got his master's and PhD and founded the company. And that's what we're basically trying to do today. And my team and I, around 15 people in the company, working on examining consequences, understanding consequences of policy changes, changes to the regulatory environment, and changes to the reimbursement and access environment, and using that to support patient organizations and companies. If you like what I'm saying today, maybe you want to take a deeper look into this report we did a couple of years ago on really the foundations for the plasma-derived industry and look at some of the challenges with the supply and demand in Europe. And that's me. It's an okay picture, a bit old, and yeah, it looked better back then. So that was just, you were not expecting. Okay. All right. So the unique nature of PDMPs. This is a little bit of some of the, just trying to, put the, set the scene. And we know, you see from the very left here, just a little overview from that perspective of the industry. The raw material, the plasma coming from the blood, around half of it containing plasma. Out of that half, much of it is water, but 7% of that is filled with the proteins that we're really using to develop the innovative products of plasma-derived medicinal products. Albumin and Igs, the big part, but also smaller proteins that are extremely important for some of them very rare diseases. I've had the pleasure of working a lot with patient organizations across the world in hereditary angioedema lacking the C1 inhibitor deficiencies and using plasma-derived therapies for the C inhibitor part of the plasma and so forth. But it's not really, that could be a sign of what really drives the let's say, it's supply and demand for plasma. And I'll try to come up a little bit with this illustration because it has some interesting insights into the nature of the plasma-derived therapies and how that, what parts of the plasma is being used and how the market ends up looking. If you start to the very left, think about, the first liter of blood being donated and collected. And if I just, for argument's sake and simplicity, say, Ig and albumin, factor VIII, and C1 inhibitor, let's just say that's the only, those are the 4 proteins of plasma. That's just for argument's sake. And actually, everything is used in the beginning. There is a demand for products that use these proteins, so everything is being used. But later on, once the next liter is sourced, the demand for products using C1 inhibitors are actually limited, or it's actually now the market or demand has been saturated. No more patients or people living with, for instance, HAE using the C1 inhibitor are in need of it anymore. But still, other parts, other medicinal products using other proteins in the plasma are still being used. And next time, it's been exhausted with the factor VIII, next time with albumin, and finally we have the immunoglobulin that is actually the driving force of the demand. And once that market and those products have been, let's say, saturated or the demand met by people living with diseases that require Ig-based products, then we have, let's say, the supply and the demand has been met. So there are a couple of interesting things. The Ig demand is really driving the need for plasma globally, because it's the last, let's say, part of the plasma that's being utilized. And at the same time, you see some important economic implications, that there's actually a multitude of proteins that can be used and sourced, which has important implications when we talk about motivations for companies to get into plasma-derived therapies, that being able to use many of the parts of the raw material to produce products is important. It also means that the effective use, the more effectively you use the parts of the plasma, the different proteins, the more you can motivate, or you can have more products covering that same cost for sourcing but research and development and manufacturing of the medicinal products. And if good competition exists, you'll be able to drive prices down and also provide, making it more available to people living with the diseases that require these medicinal products across the globe, and in Europe here in this case as well. And understanding a little bit about these fundamentals allows us also now to look at some of the potential, let's say, opportunities, but indeed some deep concerns that I have around some of the upcoming regulatory and policy changes that we're seeing at EU level. And I'll try to share some of these concerns here. It's actually the regulations around general pharmaceutical legislation, the orphan medicinal product regulation. So the Commission launched its proposals for a big pharmaceutical legislation review back in April, 26 April, that really covered a lot of basic incentive changes and changes to the whole, let's say, framework around the development and marketing of non-orphans and also orphans. So both for the rare disease space and the non-rare disease space. And I'd like to try and take you through some of the, let's say, main concerns that I have around parts of this. Now, when you devise and the Commission devises a broad piece of legislation, you're obviously targeting like all medicinal products under one, and they always have to somehow fit in. You know that's not going to be the case. And one of the important jobs for patient organizations and other stakeholders involved in some of this, let's say, sub-areas, could be rare diseases, could be plasma-derived therapies here, plasma-derived medicinal products area here, then it's really important to be aware of what are some of these, good intentions from a broad perspective that may have unintended negative consequences when you go down into some of the subsegments, like PDMPs, for example. So I'd like to take you through and share, let's say, 4 concern areas with you. The first one is that it's basically the measures. It's been an enormous pressure on the Commission from member states to really come up with a revision that were allowing, cost containment. You'll see some of the features of these regulatory changes or legislative changes are around reduced length of protection to facilitate earlier access to generics and other provisions to get generics faster. And there are also, I think we'll hear that a bit later on, also various provisions and discussions going on at member state and HTA level around how to assess some of these products that have potential pitfalls for PDMPs. But the cost containment is a major focus area. The second one is induction in incentives. You have your patents, but in order to incentivize properly development and marketing of medicinal products in general, including PDMPs, you have a number of other provisions like data protection, regulatory data protection that protects the data set being created through clinical trials and shown to regulators to get authorizations. And those are reduced with an opportunity to increase, again, get back to a longer protection periods if companies comply with certain provisions and certain categories that we'll get back to. But really the motivation to develop medicines is a concern and market them in Europe because the protections length are being shortened. Also, new categories are being introduced that provide certain linked back to incentives or lengths of protection. So the new category called high unmet medical need, it's a new, let's say, understanding and classification within the rare disease space and OMP, the orphan medicinal product space, where many of the PDMPs belong. And that you can classify for, and if you don't, companies will not get the protection that they usually have and reducing their incentives to innovate, and also new classification of unmet medical needs. And finally, there's a concern from the Commission that security of supply is at risk and certain initiatives to stockpile medicines to reduce the risk of supply constraints and the security of supply being a risk factor. All of these things, I will argue, will and may have very real negative implications for PDMPs, and that's something to be aware about. First of all, the basic cost containment measure. It's really a smart thing as we are in an inflation regime to somehow think about as a payer, how can you leverage that when you kind of have set your prices. This is a graph that shows, on the one hand, the PDMP industry, and it breaks down the cost as part of the, let's say, production and manufacturing and marketing process of medicines. And you see the dark blue to the left, those are PDMPs on average, and more, the traditional pharma products to the right. And you see the big difference being the first block. These are actually a bit, older numbers. Latest numbers just came out recently suggest that the manufacturing cost part of PDMPs is even higher than the 57, maybe even up to around the 70%. But it just emphasizes the fact here that manufacturing cost is a very high part of the cost of PDMPs, whereas that is not the case for an innovative chemically based pharmaceutical product. So it's actually, let's say, in a high inflation environment, cost for producing one more pill of a traditional pharma product is not really going to make a difference in decision around whether a company is going to supply more or less or extract itself from a certain market. It's the product is already there, and it can be a smart strategy for a payer to say, we're not going to inflation adjust, let's say, prices because you're already here, and we just, it'll have implications for your down the line investment into new therapies maybe, but right here and now we're actually, let's say, reaping some of that value that is being created by not adjusting our prices. And the fact is that, companies can't really do so much about it because it's not really a big change to the production cost because it's very little cost going into production. And in that sense, they'll stay in the market at let's say, lower prices relative to the inflation. Now, that's a different case with PDMPs where much of the costs go into manufacturing. And if we see price and cost increases there, it might have actual detrimental, and decision-making effects to change your prioritize different markets over others. If you're supply constrained and you see your cost, let's say, go up, you might change your strategy for where you supply more or less, depending on the pricing regime and your patient populations. So there's something here where this way of thinking about cost containment will have very different implications for PDMP industry compared to the traditional pharma industry. Also, these incentives that are now being built into the pharma regulation and legislation. I talked about regulatory data protection. So this is let's say, think about it as an additional protection on top and running in parallel and in addition to patents and the protections that innovative companies enjoy, allowing them to recoup research and development costs going into the development of a new medicine and have a certain level of protection. This regulatory data protection is being reduced, effectively reducing, let's say, the demand or let's say the incentives to innovate and market. However, you can actually gain back as a company some of that protection link if you market and launch your product across all the, 27 EU member states within a relatively short period of time, then you're eligible for clawing back some of that regulatory data protection that is now being reduced as the baseline. Now, for many big medicines that are marketed across and being used in big quantities, that will probably be a fair and good incentive, and many of them will try and abide with that. And the intention is, of course, from the Commission side to reduce inequity in access across the 27 member states. This is an illustration of plasma-derived factor VIII therapies and the share of plasma therapies and factor VIII deficiency treatments across member states. You see some countries, the medicines, the factor VIII medicines, a lot of it is plasma-based, the majority, but you also see in other countries recombinant therapies and other therapies are really dominating, so the plasma therapies plasma medicines are much smaller. That, of course, means that for many of these, where other alternatives exist and so forth, which is the case for many PDMPs, you might not see a big incentive or opportunity, I would even say, for companies to launch really fast across all 27 member states, because there'll be certain markets that for sure are more opportune and more important to cover and focus on, and then only, let's say, down the line, even some countries might not even be that willing to pay higher prices if they basically have many other alternatives. So the opportunity to claw back some of the regulatory data protection might be look very different from big population drugs to smaller population drugs, and even the ones where the patient populations are demanding the therapies or the medicines very differently across countries. Another thing is the new concept of high unmet medical need and unmet medical need in the non-orphan space. So this is really the Commission's attempt here to try and say, well, in, for instance, rare diseases, and many of PDMPs do, in fact, respond and treat and use for people living with rare diseases. The concept of high unmet medical need is something to, again, add incentives, add protection if you classify it for high unmet medical need. Now, one of the important things is that the Commission is looking very broadly and saying, if you have one therapy that is being authorized for a disease, you kind of after that don't really have a high unmet medical need because there's already an authorized treatment. So after that, the high unmet medical need, which is a classification that actually gives companies additional protection, not as a regulatory data protection, but market exclusivity, which is the type of protection period you get if you produce medicines for rare diseases on top. You are actually not qualifying for that. But we know that for many, many diseases, subpopulation specific concerns arise. There are pros and cons of offering a variety of different medicines and different treatment because there are certain subgroups of people living with these diseases that will have unique characteristics. And for them, it'll definitely be an unmet medical need and high unmet medical need if they were not able to get the therapy and the treatments that really correspond to their specific characteristics. And again, the intention from on top is that the Commission would like to signal, in areas where we don't have any authorized treatment, we need to try and develop treatments and market them in those areas, which is in many ways, it's a fantastic way of trying to focus areas where no treatments exist. But it kind of diverts the attention away from the fact that in areas where we have one treatment, many people living with this disease will not really be, will be fully treated with that particular treatment. There are pros and cons, and one of the big important aspects of offering PDMPs alongside recombinant therapies are exactly the opportunity to actually match a treatment with specific patient characteristics and needs. And here, there's a very, very strong link all of a sudden. If you fall out of the unmet medical need for non-orphans, and if you fall out of if you don't classify for the high unmet medical need, all of a sudden you lose important years of protection. And at the same time, there are very likely to be implications for the pricing and reimbursement discussions further downstream as well. Finally, the Commission's concern in this legislative proposal around security, supply risks, that we don't have enough medicines to treat the European people living with a number of rare diseases or a number of diseases, has led it to say there's a need to emphasize stockpiling and link that to certain provisions and incentives. And if you see the difference here on this first graphic between producing PDMPs and a chemically based pharmaceutical, you see that there's a whole different production process. And again, if we are in a supply constraint environment, which in many ways we always are in the PDMP area, the idea that you should start stockpiling would mean that you would run the risk of having to deprioritize certain markets right now and certain patient groups right now. But again, from a perspective of a traditionally produced pharmaceutical, you can produce a lot more pills and put them in storage, and that would not really have that much of a negative implication, whereas the Commission sees the upside of having stock and so forth would significantly reduce the risk of supply constraints and supply risks. But that's a whole other thing here. One opportunity, though, is maybe to reframe also to policymakers in the time that from the Commission has now presented its proposal to the discussions that are going on in Council and with MEPs, to really maybe reshape and re-push and say maybe for PDMPs, stockpiling is not so much about producing scarce medicines and put them on storage, which would have a number of negative consequences for the serving the current patient population, but rather to think about the imbalance between locally sourced donor plasma because of the imbalances that we know exist between supply and demand globally from the US to Europe and other places, which in itself, it's a mechanism that works. But now if you're concerned about locally, like a self-sufficient supply, maybe stockpiling here will work for other types of medicines. But for PDMPs, maybe the whole stockpiling argument rather goes down to the opportunity to source more plasma material from European citizens. It will be another way of reframing and thinking about security of supply and the stockpiling issue. But the way that it's reframed now by the Commission could have definitely, unintended consequences for PDMPs. So that was a little bit for me trying to set the scene around some basics around the economics of the plasma market and the production and the value chain, but also trying to put that in context of a big legislative body and proposal that is out now that really have on a number of different parameters set well-intended legislative routes and paths that though may have very unintended negative consequences for subgroups for patients and for companies and for other stakeholders that are active in this space. And I've tried to give you an overview of an idea of some of the concerns that we see when it comes to PDMPs and the new legislation. And I'll be joining the panel afterwards and be part of the discussion and some of your questions as well. Thank you so much.
Thank you, Christian, for this presentation. If fine to everyone, I would like Frank to continue on a presentation on alpha-1 antitrypsin deficiency.
1, 2. Thank you. My name is Frank Willersin, and I'm very lucky. First of all, thank you for the organizers to bring the patient in. I'm lucky because I'm with you. I'm lucky because I'm a patient, an alpha-1, and I'm diagnosed. And I'm lucky also because I get my augmentation therapy till 2008. So I would like to give you some ideas about the situation of antitrypsin in Europe today. And I will start. No. Can I have the next slide, please? Oh, here. Okay. I will say something about me, about the disease, about alpha-1 antitrypsin deficiency, about the toolbox for the future treatment, because as we know today, augmentation therapy is the best tool on the market, but in future there might be other opportunities. Then the main point is access and reimbursement of this rare disease in Europe. And some words about the patient needs. I was born with this genetic condition in 1953, and as alpha-1 antitrypsin deficiency is a lung disease and a liver disease, it is important here to say also I was a heavy smoker for 20 years, between 16 and 36 years old. And in 96, I got an infection, a streptococcus infection. I have lost my left arm by fasciitis. And in 97, I was diagnosed as alpha-1. I was diagnosed by error. Why by error? Because my wife asked me to check out my liver and my kidney values. She took some blood and make a wrong cross on the laboratory sheet. She wanted to go for potassium, but she put it on proteins. And then the laboratory gave a phone call saying, we have no alpha globulins. You should do it a second time. And so I got my diagnosis. I was not suffering from COPD. My liver was okay. I had no panicculitis. I was fine. I had lost an arm. And 1 year after this event, I said, chronic disease in my family, I have no time for that. I have to learn how to drive with one hand. I have to learn how to dress, how to eat, all these things. And I'm not suffering, so I didn't care about. And it took me around 10 years to get sensitized, saying there was something with my chromosomes, let's have a look. And I started to run expert geneticians. Finally, I got on treatment in 2008 on augmentation therapy. And as you can see, I don't need oxygen. I feel fine. I feel fine, how to say, I feel very fine for my age, and things are okay, and I'm very glad to share this with you today. So today I have a little bit COPD, but that's not very surprising because alpha-1 antitrypsin deficiency is a lung disease. So this disease, we have a prevalence in Europe about 120,000 ZZ people, which is the worst genetic condition, like me. About 95% of these of people suffering ZZs, and it's a genetic condition where only one mutation is known to create the ZZ genotype. The production of this antitrypsin is in the liver, but even there is no production or the protein is disformed. The disease is underdiagnosed by over 90%. That means that today, I think we know about 10,000 people which are homozygous, which is a tenth. Some people, they have a storage problem in the liver because the protein is disformed. And if the lung is not protected, well, often emphysema comes up. That means the density of the lung goes off, and there is no protection. By my augmentation therapy, my lungs are protected. And when I come out of the hospital, every time I feel a bit dizzy because it's a protein shock. But on the other side, I have the security that in next time, in next days, in next weeks, I'm protected. And that's wonderful. Alpha-1 is a systemic disease, can attack the vessels, immunity. And today, of course, I ask myself if I have lost my arm by a streptococcus infection because I was an alpha and not under augmentation therapy. So the treatment with PDMPs today, we know about less lung decline, about less exacerbations, less mortality, about well-being, mental health, and economic outputs. It's the best treatment for alphas I know today. What's coming up in our toolbox for the future for alpha-1 patients is, besides augmentation, substitution therapy, well, there are some chaperone molecules, work about the folding, silencing ERNR in the hepatocytes to bring down the ZZ molecules, inhaling the product with less product and directly in a short way to the lungs. There are a trial about a double dose. There are new molecules, anti-protease molecules, gene therapy function in the laboratory, and also recombinant products are coming up. But in the next 10 to 15 years, I'm convinced as an alpha that we will need PDMPs for alpha-1 treatment in this toolbox, because if we are silencing RNA, for example, well, there still is no antitrypsin in the body, and all treatment slowing down the production, we need some antitrypsin to fill the body up for immunity, for the liver, and also for the lungs. A couple of weeks, we had a congress in Dublin, and the researchers, they say, well, the disease seems quite simple, but we don't understand it really because there are so many questions. We have no answer. And now 50 years, the disease is known, but there are still, we don't know why some alphas are declined and other don't, even with treatment. why some of them get emphysema and others are sensitive to liver problems. And what about cost effectiveness? So we have to know, I would like to tell you that today in all these countries in Europe, the 46 countries of the Council of Europe, we have 46 landscapes about alpha-1 because we have countries with reimbursement, we have countries where people don't have bronchodilators, we have countries there is no vaccination. So every country has a specific profile. And the first problem, I think, is there are a couple of augmentation therapies on the market, but only one product has an access coming by the EMA to have access to treatment in Europe. And I think there should be more products. The discussion of cost effectiveness is often a refuse to get reimbursement for alpha-1 because we don't have enough clinical trials which are accepted as best result for this disease. In Belgium, for example, my treatment costs about 70 to 80,000 euros a year, and I'm reimbursed in Belgium. Belgium is a very specific country, like the other ones, and there, for me, is a kind of discrimination. The prevalence in Belgium for these people are 2,500. We know about 200. There are 10 people on treatment. I'm one of these, but other people, they are not on treatment because the Health Commission decided not to reimburse anymore for freshly diagnosed alpha. That means, for me, that's a question of discrimination because same people with the same condition in the same country, some are treated, others are not treated. And so in Belgium, the discrimination is based on time because in 2010 they decided not to reimburse freshly diagnosed. In Croatia, as I know, there are 14 patients on treatment, and there is a waiting list because the budget doesn't allow to treat more than 14 people. In the Czech Republic, the last data I've got, there are 22 people. And so on the waiting list, because, and people know each other, well, they are waiting that one of the 22 drop off in one way or another to get the place. So these situations, I think, are very uncomfortable and also unacceptable. In Poland, Bulgaria, and 20 others, there is no reimbursement of augmentation therapy. And so, as we said, 70 to 80,000, a little bit less or a little bit more, but these people are not treated, are not accepted. And I think in countries in Europe where there's no reimbursement, it's another kind of discrimination on the European level. So in 19 countries there's reimbursement, in 27 there isn't. And I know a lot of people, well, they move to Germany or to France or to Spain or whatever to get treatment. And that's one of the rules. That's okay in a certain way, but the whole situation is not okay. So here I have brought together the names of the countries, of the 46 countries, and in yellow you have the countries of the European Union. And in blue you have the countries where is a patient association. And the most important column is the red one. It's the column in these countries, alpha-1 is reimbursed in one way or another. And the situations are different. Like, for example, in the Netherlands, we have mainly 00 alphas, which are treated and reimbursed. In Luxembourg, there are 5, and they are not even ZZ, they are a little bit mixed. And in Romania, this year, we have one patient, he is treated and reimbursed. Took us 5 years to get there. And so in Croatia and in Slovenia, things are limited, and the situation is in every country different. And of course, one of the messages is we have to do things to get this in order, in best order, to get people treated in all these countries. So my last slide, what Alpha needs. We need more PDMPs, we need more products. There are not really shortages because, as you know, antitrypsin is always available in a certain way. But products who can have access to all these countries on the European market and not only one. We should standardize the medical conditions like in Switzerland or in France as alpha-1 if you are tested. They are not the same condition to get the product. The price level discussion is not perhaps a point to mention here. We have more to invest in basic research because the disease is not really known, and a lot of money is going into the clinical trial, but it seems not in the basic research, as says the researchers. We need more digital tools for the patients, well, to get data, but also to train and that the alpha-1 patients get their own experts. We should create think tanks between researchers and patients, for example, to think about what are the needs and how to go for. Perhaps we need new models of reimbursement. For example, an alpha who should get treatment can get treatment for 2 or 3 years, and then to make a CT scan of the lungs and to have a look if things are okay and working well. It could be another way to reimburse for a certain time. As we know, rare diseases are always out or a real hole in the national budget. One perspective could be to bring alpha-1 and all rare diseases out of the national budget and to create international funds, for example. And then perhaps to create other transnational help for this disease or for this kind of disease where we need PDMPs in a certain way. To think about that, I think that would be very helpful. Thank you for your attention.
Thank you, Frank, for this clear presentation, facts-based and illustrating, unfortunately, a lot of unequal access across European member states. We open now the session question and answers. And as I would like to involve also my other panelists in this discussion, if you allow me, I would first ask them to give us some comments. If I summarize really the first 2 presentations, I remember certainly cost containment and its impact, and I see diversity across member states. And it brings me to the question to you, Dagmar, and to you, Tomasz, about the recent evolution in Germany on cost containment, and to you, Tomasz, about the international context of exemptions to cost containment and so on. So, if you can answer this, please.
Yes, thank you. In Germany, we think about the system and the reimbursement, and to ensure the supply of patients, immunoglobulins of human origin were exempted from the so-called extended price moratorium in the case of new approvals or new EU marketing authorizations. The exempted price moratorium is based on immunoglobulins which have the same active ingredient, which are comparable and comparable in the dosage form. The discount then is calculated on the price from the precursor product closest to the new product, and taking into account the quantity of the package, the package size, and the strength of the ingredient. The exemption means that the price setting by the precursor product will not longer apply. The German government considered this as necessary because the pharmaceutical companies indicated that they would no longer be able to cover the manufacturing costs with the German reimbursement prices for immunoglobulins. And in addition, we had the situation that the manufacturers had also repeatedly reported supply shortages to the Paul-Ehrlich Institute in the course of 2022. The Paul-Ehrlich Institute is the Federal Institute for the Biomedical Products and responsible for the research, assessment, marketing authorization, and the batch release. The shortages of medicinal products, the biomedical in this case, should be notified to the Paul-Ehrlich Institute, and they are in contact with the Federal Ministry of Health, with our unit, and then we discuss and make decisions about legal regulations to be able to serve the supply situation in our country.
Okay. Thank you for this, because it illustrates already a concrete step in a big member state of Europe. Can you bring other examples from across Europe in this issue?
I think that's problematic because there are very, very few examples that are positive. I think Germany is sort of paving the way in many ways of actually looking retrospectively at the value of PDMPs and comparing that value to the economic measures or pricing measures within the reimbursement system. But before I comment on other countries and the way it looks in the world, I just wanted to, thank Frank and Christian for the extremely clear presentations and just reflect or put a few things in perspective. Because what we've been talking about is two elements. One is an extreme vulnerability of the PDMP's value chain from donor to patients, meaning that whatever disruption happens along that value chain, which sometimes takes up to 12 months before from donor to get to the patient, whatever disruption happens there, it really risks a derailment of this value chain and therefore accessibility of PDMPs. And we very often do not appreciate how important is the latter part, i.e. the reimbursement, the pricing, the formulary inclusion, in order for the drug to, for the medicine to reach the patient. So that's also part where the vulnerability starts. And then if we look at it from a different perspective, then we really have availability, accessibility, and sustainability. And bear with me, I'll try to be quite succinct, by which I mean many PDMPs are not available in Europe because their regulatory status is simply not there. They are either not used or used off-label. It's a case often with immunoglobulins in many indications. So that's the first part that reflects on the vulnerability, because not from a patient perspective, not being able to get the product, the medicine, not because it is not reimbursed, but because it's simply not even allowed in, and yet it may be the only treatment that is effective, can be disastrous. Then we have the accessibility, which both Frank and Christian referred to, which is typically to do with reimbursement. Are we reimbursing a particular medicinal product for the right group of patients? And it's a sort of a twofold equation. One, are we reimbursing it? Therefore, is it covered? But also for what eligible group? And I think, Frank, you have also mentioned that, very often the restrictive eligibility is extremely damaging, either discriminatory, because there is no good reason why one patient should get it and the other one shouldn't, or it becomes an economic measure. Poland is a good example of very restrictive eligibility criteria. For instance, immunoglobulins are part of what is called a drug program. Drug program has a very specific budget, and therefore inclusion criteria for patients are quite restrictive. So you may not be included purely because you do not fit a particular annual budget. And that's already the cost containment measure, even though indirect. And then finally, we have the sustainability, which is to do with pricing and the so-called clawback taxing and any other retrospective measures that are punitive to the PDMP industry. So we have some extreme example. Greece, 45% clawback tax, regardless of what value of the medication there is, whether it's a highly innovative, new oncology drug, or whether it's a generic. The same clawback tax is applied. And as I say, 45% in relation to an industry that spends over 50%, I think you said, Christian, in just manufacturing. You cannot reallocate those costs. They are fixed costs. And I'm not saying that biopharmaceutical industry has it easy because they can reallocate costs for marketing. They can, so in that sense they are different. Of course, they also, when they're supplying value, should not be forced to do so. So I think the problem is that there are many systems. We have traditionally Italy and France, for instance, applying economic measures or clawback measures or cost containment measures only to the plasma from outside their countries, so favoring the plasma from within. There are countries like Poland that actually have made strides, not as concerted as Germany, but at least allowed price increases, which is unheard of. It's the only group of medicines in Poland that have recently been allowed a price increase, despite a flat rate or moratorium that Dagmar has spoken to, a very similar measure. So we are seeing some movement in there. But I think the important thing is it's about policy. So very few governments actually stop and start to reevaluate what PDMPs bring to the society, how big of an impact they have, not just therapeutically, but socioeconomically. And only if we really drive the policy and prioritization, we can really then say, well, if it has such a high value, if it responds to high unmet medical need, then therefore we should not apply cost containment measures. And then you will have examples that go a long way, not quite there yet, like Germany, partially like Poland, and also the very end of the value chain, like tendering. Ireland has, for instance, introduced what they call the smart tenders, in order to allow as many PDMPs in the market that are better or worse tolerated by patients. There are smart tenders. So every product can be purchased under one tender, unlike many countries which are price-driven, meaning one product is only available, and that may not be the most tolerated product for many patients that have been treated differently. I know I've spoken quite a lot and in a quite complex manner, but hopefully it makes sense. So what I wanted to really illustrate is that we have a long value chain, availability, accessibility, sustainability, many of which are affected by cost containment measures that can be very myopic. You spoke of cost effectiveness. Very often cost effectiveness is not the best measure because it can be the only life-saving treatment. Whether or not cost effective, it is still life-saving. Anyway, I'll finish at that to allow some time for both Frank and Christian to answer questions.
Thank you for all explanations. Even if I have other questions, I would also like to give an opportunity to the audience to ask specific questions. I'm not sure I can see it because of the spots which are, but if anyone is willing to. If not, I will indeed ask maybe to Frank or to Christian, sorry, or any other one here present. It is often by the competent authorities an approach towards one product, as it is mentioned. Would some kind of more holistical approach to these PDMPs be something, because you mentioned first liter and last liter approach, shouldn't it be more holistic from the side of the competent authorities? And what would be the impact on the access to these products?
I think it's from a top down looking at it, the more you can utilize the different proteins in the plasma, the more products that are simply available to cover the cost of development. So in that sense, it is a very effective way to try also and drive down prices. Of course, in the end, it might also be a point for the companies to try, and there's a motivation to try and strive to develop new products that utilize, let's say, parts of the proteins that are not fully utilized, and to try and make innovative products from that. It is probably a difficult, let's say, dilemma for a health system and a pay organizations to try and assess, let's say, knock-off implications of using another treatment that is less favorable to a patient group and try to link that together with another treatment because it let's say drives from the same plasma donation, if you will, or from some of the same proteins. But there's definitely something where I also think that let's say the companies also have a stake in and a intrinsic motivation of also trying to develop products that utilize as much of the protein as possible, especially those parts of the protein that we saw from the plasma economics is not being is quickly being emptied.
And towards the payers, you have any tips and tricks to convince them of this upfront cost of PDMPs, which they tend to neglect?
I think we're on to something. What Frank says and what Tomasz is saying as well is, and I'd really be happy to hear also from the German side what made you kind of made exemption from PDMPs from your cost containment measures. But I think some of the things that we see is the notions of cost effectiveness thresholds. They rarely do apply very effectively to, for instance, rare diseases where the clinical data available to show the one side of the, let's say, the effectiveness side of the cost effectiveness ratio doesn't really conform well to the normal statistical methodologies that really requires a randomized controlled trial with many patients and, in that world, high statistical power and low uncertainty and all these things. Then the kind of threshold idea compared to cost, somehow makes sense. But when we go into rare diseases where due to the lack of opportunity to either to completely do a randomized controlled trial, you have to do a single arm trial and compare with some natural history or other existing measures, all of a sudden the existing methodologies to assess this data, they become much more impotent and not really so effective. And then you still take that data and put it into a cost effectiveness measure, and what you get is that, well, the risks are, the uncertainty around the effect of this treatment is so large that you basically have to have an enormous, really, really low price to kind of justify it. And whereas the opposite is often the case because you have very few patients to cover your costs, so prices will tend to be higher than for a blockbuster type of drug. And I think these are some of the things where consideration about special pathways, Frank had like special budgets, that's another way of thinking about it, but definitely special considerations. It doesn't have to be, from our perspective, it doesn't have to be a black box that you just allocate without thinking about it, just allocate a lot of money because it's a special disease, but you have to think about ways of having pathways that just simply take into account the specificities around having few patients when you look at data from a clinical trial, for example.
Maybe a question then to all of you, because besides these specificities, payers do actually reimburse products which are much more expensive than these 70,000 euros a year for this alpha-1 antitrypsin product. They pay 1.9 million euros list price for Zolgensma in SMA, rare disease. You mentioned cost effectiveness, maybe not the solution, but for some rare diseases, ICERs, if we can use them, the incremental cost effectiveness ratios, they go beyond the usual thresholds used by NICE. So isn't there an issue about awareness on diseases and companies in this field as compared to small molecule manufacturers which are sitting in committees and commissions advising ministries in these member states? What do you think about this?
Let me just make a quick comment and I'll yield the floor to an actual decision maker here on my left. But I think first comment about the cost effectiveness. The traditional cost effectiveness countries, UK, Netherlands, and Poland, with explicit ICER thresholds, have dropped them. So these are the countries that have realized that restrictive ICER or fixed ICER is completely unviable in relation to rare diseases or niche oncology or breakthrough therapies. That's why we are having Zolgensma and many others, Libmeldi, all those being reimbursed at a much higher price point and in fact much less cost-effective treatments than, say, Alpha-1. And I think that's the major trend. It's the value-based assessments that typically take a form of multi-criteria decision analysis, taking more than just cost-effectiveness. Cost-effectiveness becomes a benchmark. And if we don't have it, if we don't have cost-effectiveness data, it becomes essentially an argument to collect more real-world evidence data. And I think that's what we should focus on. When we have PDMPs, allow PDMPs to generate that data. But in order to generate that data, you need to have the coverage of all the patients. They need to be able to get the treatment, to be able to show the real impact, the value of it. So yes, indeed, cost effectiveness is becoming less and less used in relation to rare diseases. I think it's becoming almost irrelevant in some cases. And where it is relevant, I think it's a retrospective analysis once we get the data rather than based on clinical trials. And I think PDMP specifically, we are speaking of a group of products that have been in the market for an extremely long time. And it has a tendency in some of the payers' minds to treat them like generics. Well, they've been around for 40 years, therefore they're genericized, they're commoditized, which is not the case, because in many cases there's no alternative.
Thanks for these clarifications, but what about my question then about awareness and about being present in the committees advising competent authorities? If I speak about Belgium, which has already been mentioned, classical pharma, big pharma is represented in committees and can act and is asked also for reforms and so on. So is it because of the scale of the organization and so on? Should we do something about that? Should we create more awareness? Yeah.
Well, I think, of course, the patient is the most important part in the story, because on one side we are suffering, and there are basic problems for the daily life, quality of life. On the other side, I think, well, we can create awareness and we can sensitize in all countries about PDMPs, about alpha-1, for example, because, well, we have the possibility to interconnect in communication, simply not in a scientific way, but in a communication way, to speak, to tell our stories, and to find solutions for our best quality of life. And that means, for example, in alpha-1 antitrypsin, now the National Patient Association will create a European structure, which is called Alpha-1 Europe Alliance, and which will be launched at the end of the year. And this is a structure a little bit like IPPC or EHC, so that the whole patient community can speak with one voice on the European, on the international level. And these kind of structures are tools to get the disease known and the problems known. And for me, this kind of communication of advocacy work is the most important.
Probably it should happen, because you mentioned in your slides also one solution for alpha-1 being to follow up patients and after 3 years make a scan of the lungs to see, if I understand you well, did the product deliver what it was intended to deliver? And if so, the payer should pay. If not, we can discuss about it. We go to what is called managed entry agreements, pay for performance. And these schemes exist already since years in some countries, again, at various levels, with discounts, with risk-sharing schemes put in place. So again, what is already existing for years should indeed, by this kind of awareness and by this kind of focus, probably be also a solution to this type of diseases, because clearly it hasn't been discussed till now. So it stresses this, again, the way to look maybe somewhat broader outside of here plasma-derived medicinal products, because I see a link also with what is happening with ATMPs. Again, I'm aware of one ATMP being financially stuck down by a price reduction mandatory of -20%, because 10 years ago, the first one had a price and it's already 10 years on the market, so it should be cost containment -20%. So they are also in the same type of category of being products for which exemptions should indeed be considered and for which rational schemes can be developed, because they exist already in oncology, in orphan disease, in rare diseases, and they should be extended to plasma-derived medicinal products, for instance. I also have a question maybe for you, if you have already some kind of data on what this exemption on immunoglobulins had as a consequence on access for patients in Germany. Are there already data, or is it too early?
I think it's a bit too early because the system started at the end of last year, and the supply situation for the blood plasma products, especially the immunoglobulins, remained strained still in Germany. But there are currently no concrete indications for upcoming supply shortages. What I can say that we have currently around 7 preparations that are still in short supply, but there are still 6 preparations that have been available again at the end of April. So, but it is not clear if it's from the change of the legislation or about the availability, because that is one thing I would like to say, that the plasma-derived products, we have another ground than in case of the ATMPs. They are donated products. We have then their influence of the plasma supply and the donor availability, and that is for me a difference regarding to the ATMPs or other products. So we must have this in mind, that is a very specific product, and the long production manufacturing procedure we have as well, so that it is a specific product from human origin, and this we must have in mind and care for it.
I completely agree that these are distinct classes of medicines, but sometimes they face the same challenges, apparently. Yeah. And then it might be a good idea to try to be bigger, to bring the same messages. We are still running a little bit out of time, but I don't know whether there are still other pending questions for this panel. If it's not the case, well, we learned a lot about the challenges across Europe on cost containment, on sustainability, on supply. Seeing the solutions which may be different depending on the disease. Sometimes some diseases having additional challenges if they are still more rare than other ones. I hope you enjoyed the session, and I want to thank all panelists for their comments, presentations, and discussion.
Thank you.
Thank you.
Thank you.